Welcome to this deep dive into Chapter 12 of Simpson's Forensic Medicine. We're covering heat, cold, and electrical trauma today.
That's right. And if you're joining us, you are likely a medical student prepping for exams, maybe a junior doctor revising medico-legal principles, or even a senior clinician revisiting the foundations.
Yeah, and we want to be incredibly clear right off the bat here. What we're doing today is, well, it's building a conceptual framework.
Exactly. It's designed to support your study, help build those structural anchors in your mind, and really make the material exam ready by focusing on the why behind the pathology.
And this is crucial, this is absolutely not a replacement for the textbook itself.
No, not at all. We strongly encourage you to open your copy of Simpson's Forensic Medicine, turn to Chapter 12, and read along to consolidate what you learned with us.
Because that structural foundation is, it's everything in forensic medicine.
It really is. Rote memorization will only get you so far, especially when you're sitting in an exam or, standing at an autopsy table faced with an atypical presentation.
Right.
We are going to integrate the pathology, the physiological mechanisms, the scene findings, and the law. If you understand the underlying physics and biology, you can reason your way through almost anything.
And the scenario we're tackling today it's deeply compelling. Usually when we think of forensic pathology, the mind naturally goes to interpersonal violence, blunt force trauma, gunshot wounds, forces wielded by human hands.
But not all fatal forces have a human origin.
Exactly. Sometimes the environment itself becomes the lethal agent. We're talking about extremes of temperature or the sudden invisible surge of an electrical current.
Whether it's the chaotic destruction of a house fire, the silent progression of hypothermia out in the snow, or a lightning strike, these elements leave highly specific pathological fingerprints on the body.
Which brings us to the core challenge of this entire chapter.
Yes, the medico-legal challenge. As a clinician or pathologist, your primary problem when examining a body subjected to heat, cold, or electricity is differentiation.
You're constantly having to ask yourself, is what I'm looking at an ante-mortem injury? Meaning, did it happen while the victim was still alive and reacting?
Or is it a post-mortem artifact, just environmental damage inflicted on dead tissue? Or, most treacherously, is it environmental mimicry?
Because the environment is an incredible illusionist.
It really is. It can actively disguise the signs of foul play, or it can create injuries that look exactly like a homicide when no crime occurred at all.
Okay, let's unpack this by looking at how thermal energy interacts with living tissue. When we talk about injury caused by heat, we're fundamentally talking about energy transfer, right?
Precisely. You have thermal energy coming from a physical force, like boiling water or a hot iron or perhaps a chemical source. That energy transfers into the skin.
But the injury doesn't just happen automatically the second there's contact.
No, it only occurs when the rate of that energy transfer overwhelms the skin's innate capacity to dissipate heat. The human body is essentially a biological engine that's very good at venting heat.
Like a radiator.
Exactly. Our skin, particularly through the capillary networks, acts like a radiator. That's why you can briefly touch a relatively hot surface and pull your hand away without a burn. Your skin absorbs the heat and your blood flow rapidly sweeps it away.
Dissipating it before the local tissue temperature rises too high.
Right. But there's a mathematical threshold where that system fails. When absorption outpaces dissipation, local tissue temperature begins to climb. And the numbers here are fascinatingly specific for your exams.
Let's hear them.
Below 44 degrees Celsius, the skin can tolerate the heat with very little local cellular damage, unless the exposure is prolonged for greater than 6 minutes.
But once you cross that 44-degree threshold,
The biology begins to break down. From 44 to 51 degrees Celsius, the destruction curve goes nearly vertical. Within that narrow 7-degree window, the rate of cellular destruction literally doubles with every single degree rise in temperature.
wow, it doubles every degree.
It's a profound acceleration. At 44 degrees, you have a slow burn. At 45, the cells are dying twice as fast. By the time you reach 51 degrees Celsius, the epidermal layer is being rapidly and irreversibly destroyed.
The proteins denature, cell membranes rupture, the tissue dies.
And if the temperature of the source exceeds 70 degrees Celsius, the duration of contact almost doesn't matter anymore. You are looking at instantaneous, full-thickness destruction of the skin.
So when you're documenting a burn, you always have to conceptualize it as a strict equation. The absolute temperature of the source multiplied by the duration of application.
Always.
Which naturally leads us into how we classify and document these injuries, because precision in medical legal documentation is absolutely non-negotiable.
If you're writing a report that might end up in court, you cannot be vague.
Historically, people talked about first, second, and third-degree burns. First degree being simple redness, second involving blisters, and third being total destruction. But clinically, we've had to pivot away from that, haven't we?
We have. The older degree system didn't give reconstructive surgeons enough actionable information regarding tissue viability and healing potential. The modern clinical classification divides burns based on precise depth.
Superficial, partial thickness, and full thickness.
Correct. Superficial burns are confined to the very top layer, like a severe sunburn. You see erythema, mild blistering, but it heals by peeling in 5 to 10 days without scarring.
But partial thickness is where it gets complicated.
Yes, because it destroys the epidermis and extends down into the dermis. So we divide this into superficial partial thickness and deep partial thickness.
And here is the clinical paradox that always trips people up. It's so important to grasp. You'd naturally assume that a deeper burn is automatically more painful.
But that is not how the neurology works. Superficial partial thickness burns are exquisitely, agonizingly painful.
Because the protective outer layer is stripped away.
Leaving the sensory nerve endings in the upper dermis exposed, raw, and highly irritated by air currents. But in a deep, partial thickness burn, the heat has penetrated far enough to actually cook and destroy those very nerve endings.
So, ironically, a much deeper burn might present as less painful.
Or even completely painless in its center. It was a critical clinical observation.
And then you have full thickness burns.
Where all skin elements, including the deep regenerative layers, sweat glands, and hair follicles, are entirely destroyed, these carry a massive risk of severe scarring and almost always require surgical grafting.
So that covers the severity or depth. But assessing the extent of the burn across the body is arguably even more critical for survival.
Extent dictates the massive fluid shifts, the risk of shock, and the statistical probability of survival.
For a rapid assessment, clinicians use the rule of nines, assigning 9% of total body surface area to the head, 36% to the trunk, 18% to the arms, which is 9% each, and 36% to the legs, plus 1% for genitalia.
It works well for an average-sized adult in a triage scenario, but it has significant medico-legal and clinical limitations. It routinely overestimates total body surface area.
And it completely fails with kids.
Right, it doesn't account for proportional changes in human anatomy across different ages. An infant's head makes up a vastly larger percentage of their total surface area compared to their legs.
Apply the adult rule of nines to a baby, and your fluid resuscitation calculations will be dangerously off.
Which is why the gold standard, especially in pediatrics, is the London-Browder chart. It adjusts those percentages dynamically based on the age and BMI of the patient.
It's the standard of care.
And if we're evaluating overall mortality risk, we have to look at the clinical trifecta. It's the combination of the extent of the burn, the increasing age of the victim, and crucially, the presence of inhalation airway injury.
The airway injury is a huge factor.
If a patient presents with all three risk factors, their statistical mortality risk rises exponentially, often approaching 100%.
Okay, let's unpacking this distinction between dry heat, like flames, and moist heat, which we classify as scalds. This usually involves hot liquids like water, oil, or steam.
A major differentiator you'll notice right away is the appearance of the tissue. If you see deep black charring, you are almost certainly dealing with a dry burn.
You simply do not see charring in a scald injury.
Not unless the liquid is something with an insanely high boiling point, like molten metal. Water acts as a temperature ceiling. Boiling water cannot exceed 100 degrees Celsius at standard pressure.
It'll destroy skin, but it won't carbonize it.
Exactly. But the most vital medico-legal aspect of a scald isn't just depth, it's the pattern. The pattern is a physical record of the event. When interpreting scalds, gravity is your most reliable, completely objective witness.
Let's visualize that. If someone is completely immersed, the examiner will see a distinct fluid level line.
Like a high tide mark on the skin. A sharp horizontal demarcation between the scalded submerged tissue and the perfectly intact skin above the waterline.
But splashes and pores look completely different.
With a splash, you see punctate, irregular areas of scalding. And if fluid is poured, it creates distinct rundown tracks. As the hot liquid runs down the skin, it transfers heat and cools off.
So the burn is deepest at the top.
Deepest at the initial point of contact, becoming progressively more superficial as it moves downward. These tracks follow gravity perfectly, giving the pathologist a definitive marker of exactly how the victim was oriented.
Standing, lying down, leaning, it's all right there.
Invaluable evidence when corroborating or refuting a witness's account of an accident.
Which leads us into some of the most difficult work a forensic physician has to do, distinguishing between an accidental scald and a non-accidental injury, or NAI, in children.
A profound responsibility. You have to ask, does the story match the physics? Accidental scalds in children are overwhelmingly spill injuries. A toddler pulling a boiling kettle off a counter,
Water cascades down.
yielding highly irregular margins. The depth varies wildly because the water cools as it spreads over clothing. You typically see a spill pattern on the face, chest, or a reaching arm. It looks chaotic.
Because accidents are chaotic. But intentional scalds, cases of horrific abuse, paint a highly ordered picture, usually from forced immersion.
Yes, someone physically holds the child down into scalding water, and forced immersion yields a highly specific, undeniable pattern. A bilaterally symmetrical glove and stocking distribution on the hands or feet, or massive symmetrical burns on the lower half of the body.
With uniform depth.
Uniform depth because the skin was submerged at an equal temperature for an equal sustained duration. But the most critical diagnostic signs are the areas of sparing,
Where the skin is magically unburned in the middle of a massive scald.
because it tells you exactly how the child was held. If a perpetrator forcefully presses a child down against the cool porcelain bottom of a bathtub, the skin trapped in tight contact with that porcelain is protected from the hot water.
So you see massive burns everywhere else.
But clear, unburned staring of the buttocks or the creases behind the knees because the legs were forcefully bent. Symmetrical burns with distinct sparing of skin folds is an immediate, massive red flag for abuse.
It's grim, but recognizing that pattern saves lives. Before we leave heat, we need to touch on hypothermia. Systemic heat overload. Core body temperature exceeding 40 degrees Celsius.
This is where internal heat generation or environmental retention massively outcases the body's ability to sweat and cool down.
Yeah.
We divide it into exertional and non-exertional.
Exertional being athletes or military recruits in heavy gear.
And non-exertional typically affecting the elderly during heat waves. But in forensic practice, hypothermia is inextricably linked to toxicology.
Because drugs like cocaine and amphetamines basically hijack the body's thermostat, drastically ramping up the metabolic rate.
The body produces massive amounts of internal heat. And prescribed medications play a huge role too, particularly certain antipsychotics and anticholinergic drugs. They interfere with the hypothalamus,
And crucially, they can stop you from sweating.
which is our primary mechanism for cooling down. If a drug stops you from sweating, your core temperature can skyrocket into fatal hyperthermia, even in a moderate environment. The radiator has been shut off.
So what does the pathologist actually find on the autopsy table in these cases?
It is notoriously nonspecific. There is no single pathognomonic lesion, no unique smoking gun inside the body. You might find diffuse petechial hemorrhages on the serosal membranes
Severe congestion in the lungs.
and microscopic features of profound hypovolemic shock. Because the internal pathology is so vague, the diagnosis rests almost entirely on scene correlation.
Measuring the ambient room temperature, the clothing, the tox screen. Without those, an autopsy alone often cannot definitively diagnose hyperthermia.
We need the whole picture.
Okay, let's transition to the macro scale. The pathological investigation of fire deaths. The whole building burns. We start with the fire triangle: oxygen, fuel, and heat.
And it spreads through radiation, convection, and conduction. Understanding spread mechanisms helps investigators distinguish between smoldering fires and flaming fires.
Smoldering being a cigarette on a couch.
Burning slowly, producing localized heat damage, but churning out massive, lethal quantities of carbon monoxide and toxic smoke. Flaming fires are oxygen-rich, spreading rapidly and causing widespread structural destruction.
Scene correlation is paramount here, too. Where the body is found tells you the timeline of death.
If a victim is found peacefully in bed, no signs of struggle, it strongly suggests they were rapidly overcome by carbon monoxide in their sleep, long before flames reach them.
But if they're found collapsed in a hallway or under a window,
It implies the victim was alive, conscious, and physically capable of purposeful movement after the fire started. They recognized the threat and tried to escape. That single detail changes the autopsy approach entirely.
right, and when the pathologist starts that autopsy, they have a strict checklist: identity, vitality, cause, manner, and why they couldn't escape. Let's start with identity. In a severe fire, visual identification is out.
Attempting visual ID on a severely charred body is highly prone to catastrophic errors. Intense heat grotesquely distorts facial features and destroys fingerprints.
You can't just rely on a family member recognizing a watch.
You must pivot to robust, objective scientific methods. Dental examination is the gold standard. Enamel and dentin are incredibly resilient to heat. DNA is another major tool, though getting a sample is tough.
Digging into deep protected muscle or bone marrow. But before any of that, X-rays.
Full-body post-mortem radiography must always be performed before physical dissection. It's an absolute rule. X-rays reveal healing fractures with unique calluses or surgical prostheses with serial numbers for ID.
And forensically, they show hidden metallic projectiles.
Finding a bullet lodged deep in the tissue instantly shifts the paradigm from a tragic accident to a homicide concealment case.
Here's where it gets really interesting. Proving vitality, proving they were actually breathing the fire. How do you do that if the body is totally charred?
You look for physical and chemical evidence of active physiological responses. A dead body doesn't breathe. A living person forcefully inhales superheated gases and soot.
So you look for soot in the airway, but just soot in the mouth isn't enough, right?
No, smoke can passively drift into an open mouth. The highly reliable sign is finding dense, black soot drawn deep down into the trachea and branching bronchi, specifically below the level of the vocal cords.
Because that requires active muscular inspiration.
Exactly. We also check the stomach. Soot in the stomach proves gag and swallow reflexes were functioning. And we'll look for vital thermal injury, blistering, and edema on the mucosal lining of the throat.
A dead body won't produce an inflammatory reaction.
Never.
And chemically, we measure carboxyhemoglobin, or COHB, in the blood. Carbon monoxide binds to hemoglobin with an affinity roughly 200 to 250 times greater than oxygen.
It forcefully kicks oxygen off the red blood cells and suffocates the victim from the inside out.
So if you find a massive level of COHB, you know they were breathing the smoke. What's the fatal threshold?
Generally, a COHB saturation level greater than 50% is reliable evidence they died from carbon monoxide toxicity. But exam boards demand you understand the nuances.
Because sometimes they clearly die in a fire, but the COHB is really low, like a car crash fire.
Yes, a flash fire. The environmental heat is so intense and oxygen is consumed so instantly that the victim is killed almost immediately by thermal shock or oxygen depletion. They simply die before they can inhale enough carbon monoxide.
And baseline levels matter too. A heavy smoker might walk around with a baseline of 20%.
Or an elderly victim with severe ischemic heart disease might succumb to a fatal cardiac arrhythmia when their COHB reaches only 15 or 20%. The toxicology must be interpreted within the individual's unique pathology.
Let's talk about environmental mimicry in fires. The extreme heat causes physical changes that look terrifyingly similar to ante-mortem trauma, starting with the pugilist attitude.
The boxer's stance. Arms and legs drawn up tight, fists clenched. To an untrained eye, it looks like evidence of a struggle, like they were fighting off an attacker.
But it's purely post-mortem, right? Driven by thermodynamics.
Entirely. Flexor muscles are bulkier than extensor muscles. When extreme heat denatures and shrinks the muscle proteins, the flexors generate vastly more force than the extensors, forcefully pulling the limbs inward.
It happens whether they were dead or alive before the fire.
It tells you nothing about their final moments.
Another deceptive artifact is skin splitting. The shrinking skin tears open under tension, looking exactly like severe lacerations or stab wounds.
They mimic sharp force trauma remarkably well. But we differentiate them by looking for vital reaction. If a living person is slashed, they bleed profusely and the surrounding tissue bruises.
Heat splits lack all of that.
They are clean, sharp, and entirely devoid of active hemorrhage or bruising.
But the most famous one has to be the heat-related extradural hemorrhage. You saw open the charred skull and find a massive collection of blood pushing against the brain. It looks just like a traumatic epidural hematoma from a hammer strike.
It's a classic, dangerous trap for pathologists. When the skull bone heats up dramatically, the liquid blood inside the spongy middle layer of the skull, the diploes and the venous sinuses, literally boils.
And boiling liquids expand violently.
The expanding blood is forcefully extruded from the bone and pools in the extradural space, stripping the dura mater from the skull. It mimics a traumatic hemorrhage perfectly in shape.
So how do you prove it's just boiling blood?
Physical consistency and color. A true traumatic hemorrhage is normal blood, dark red, and jelly-like. But a heat-related hemorrhage has been cooked. It becomes a friable, crumbly, chocolate brown, spongy mass.
It looks like cooked liver.
Yes, and its presence alone, without underlying vital skull fractures, must be interpreted as a thermal artifact.
Okay, let's transition completely from the destructive expansion of heat to the insidious slowing down of biology. Cold injury, hypothermia. Core body temperature dropping below 35 degrees Celsius.
And the environment plays a massive role. Immersing a human in cold water strips away core heat 20 to 30 times faster than dry air.
Vulnerability varies wildly. Body mass index, extreme age, but a major contributory factor forensically is alcohol intoxication. It's a vasodilator.
Right. It relaxes the blood vessels near the skin, forcing warm core blood to the surface. It creates a terrible paradox. The intoxicated person feels flushed and warm.
But they're actively radiating their core heat out into the freezing environment. They're freezing to death faster while feeling perfectly fine.
The descent into fatal hypothermia has distinct stages. Mild hypothermia features vigorous, uncontrollable shivering to generate heat. Moderate hypothermia brings cognitive decline, confusion, and poor judgment.
But the critical failure point is when the core temp drops below 32 degrees Celsius.
That is the tipping point.
Yeah.
The shivering completely stops. The body's last endogenous heat-generating mechanism shuts down. Core temperature plummets into severe hypothermia, leading to lethal arrhythmias, ventricular fibrillation, and death.
What's fascinating here is how subtle the pathological signs of cold injury can be on the autopsy table. Externally, you look for frost erythema.
A bright pink or purplish discoloration over large joints like knees and elbows. To a police officer, it looks like blunt force bruising.
But incising the tissue reveals no red blood cells in the fat. It's just plasma leaking from damaged capillaries. And internally, the famous finding, Wisniewski spots.
Highly characteristic, though not 100% pathognomonic. These are tiny, blackish-brown hemorrhagic erosions scattered across the gastric mucosa.
Extreme physiological stress causes minute stomach hemorrhages, and the stomach acid converts the hemoglobin into hemotin, turning it dark brown or black.
Yes. But as a vital distinction for exams, Wisniewski spots can occasionally be seen in deaths from severe sepsis, shock, or acute alcohol misuse. Context is everything.
Hypothermia also triggers bizarre behavioral artifacts. Scene mimicry that looks like a violent crime. The first is paradoxical undressing. Victims found naked in the freezing snow, clothes neatly folded.
As the core temperature drops, cognitive dysfunction deepens into profound delirium. The hypothalamus misinterprets signals. The exhausted muscles controlling peripheral blood vessels suddenly relax, causing a massive flush of warm core blood to the skin.
And the delirious brain registers that sudden flush not as cold, but as a burning, unbearable heat.
So they strip off their clothes to cool down, massively accelerating their own death. Without understanding this, investigators assume sexual assault.
Another terminal behavior is the hide-and-die syndrome.
A primitive self-protective behavior. The dying brain reverts to evolutionary instincts, seeking out a small, enclosed space, crawling under a bed, burrowing into leaves.
It looks exactly like a killer murdered them and concealed the body.
Differentiating requires disciplined scene analysis, looking for undisturbed footprints, no drag marks, no signs of struggle.
Let's move to our final mechanism, electrical injury and lightning. To understand electrical trauma, you have to grasp Ohm's law. Current equals voltage divided by resistance. The current kills you, not the voltage.
If we connect this to the bigger picture of domestic electrical injuries, the voltage is usually fixed at 110 or 240 volts. So resistance determines life or death. Thick, dry skin has massive electrical resistance, up to 1,000,000 ohms.
But add water and that protection vanishes.
Resistance plummets to a few hundred ohms. The current spikes massively, and the human heart is exquisitely sensitive. Most fatal electrocutions cause ventricular fibrillation. An alternating current of just 50 milliamperes can trigger lethal VFib.
And alternating current AC is actually more dangerous than DC.
Yes, far more likely to precipitate fatal arrhythmias.
This leads to a horrifying side effect, the hold-on effect. The person is literally trapped by the electricity.
When a person grasps a live wire, the massive current overrides voluntary muscle control. Above roughly 30 milliamperes, muscles go into violent tetanic spasm.
And because the flexor muscles of the hand are much stronger than the extensors, just like in the fire pugilist stance,
The hand is forced to violently clench into a tight fist. They grip the live wire tighter. They are conscious, in pain, but physically incapable of letting go, continuously pumping current through the heart.
when analyzing the physical body, the lesion pattern is vital. Firm, direct contact produces a classic contact blister. The heat boils the tissue fluid instantly.
The roof of the blister collapses inward, leaving a concave crater with a raised rim, surrounded by a pale areola of blanched skin from severe vasoconstriction.
But if the wire is just a millimeter away, jumping the gap.
You get a spark burn. The heat melts skin proteins into a hard fused nodule of yellow or brown keratin, And high voltage can create multiple arcing spark burns called crocodile skin.
Then there's the incredibly frustrating scenario for pathologists. The plugged-in hairdryer dropped in the bathtub. The silent killer.
Cap water is an excellent conductor. When submerged, the current doesn't enter through a single point. It spreads out evenly over the massive surface area of the wet skin.
Diffusing the thermal energy so widely it doesn't burn the tissue. Lethal shock. 0 burn marks.
Perfectly healthy-looking body, 0 entry or exit marks. We have to rely on a scanning electron microscope with energy dispersive X-ray spectroscopy, SEP-EDS.
Looking for metallization.
Electricity blasts microscopic metal fragments from the wire into the deep layers of the epidermis. We detect the elemental signature to prove the skin was part of a live circuit.
We absolutely cannot conclude without discussing lightning. Millions of amps, staggering voltages. It's a violent triad, massive current, explosive heat, and a concussive blast wave.
The blast wave is profound. The superheated air expands faster than the speed of sound, creating thunder. It acts like a bomb blast, rupturing eardrums and causing pulmonary contusions.
And it creates massive scene mimicry, blowing shoes clean off, shredding clothing, leaving the victim naked.
Law enforcement assumes a violent sexual assault. The pathologist has to look for subtle signs: localized singeing of body hair, magnetization of metallic objects, and the ultimate pathognomonic marker.
The Lichtenberg figure.
The most stunning visual finding in forensic pathology. It's not a true thermal burn. It's a reddish, fern-like fractal pattern, exactly like a branching tree, caused by the chaotic shower of electrons driving red blood cells out of capillary beds.
Often following damp sweat tracks.
Yeah.
And it's transient, fading within 24 hours if they survive. But if you see it, it is definitive proof of a lightning strike.
Absolute proof.
All right, we've covered an immense amount of ground. Let's make sure these concepts are firmly locked in with a rapid, single best answer recall session. I'll throw a few scenarios at you, the listener. Answer out loud or clearly in your head. Ready? Here is your first scenario. You are examining a toddler presenting with a severe scalds. You observe a bilaterally symmetrical glove and stocking burn distribution on the lower limbs with uniform depth. Crucially, there are clear, unburned areas of skin sparing on the buttocks. What specific event does this pattern strongly differentiate? Think about it.
If you said this differentiates intentional forced immersion abuse from an accidental spill, you are spot on. Accidental spills are chaotic. Symmetrical burns with targeted sparing indicate forced immersion. Revisit the scald section of Chapter 12.
Next, you are performing an autopsy on a fire victim. You need to prove vitality, that they were alive when the fire started. What is the single most reliable macroscopic visual sign you are looking for in the respiratory tract?
You are looking for dense soot drawn deep into the airways, specifically below the level of the vocal cords. Soot in the mouth can be passive. Deep soot requires active breathing. Revisit pathological investigation of bodies recovered from fires.
Moving on, a charred body presents with a large collection of crumbly, chocolate-brown blood pooling outside the meninges. Why must you not automatically diagnose this as ante-mortem blunt force trauma?
Because you must recognize it as a heat-related extradural hemorrhage. It is a post-mortem artifact caused by extreme heat boiling and expanding the blood inside the skull. The crumbly brown texture is the giveaway. Revisit deaths occurring during a fire.
Let's drop the temperature. Autopsy of a hypothermia victim found in the snow. You open the stomach and find tiny, blackish-brown hemorrhagic erosions in the gastric mucosa. What are these called, and are they entirely exclusive to hypothermia?
Those are Wisniewski spots, highly suggestive of fatal hypothermia, but not entirely specific. They can occasionally be seen in sepsis, shock, and acute alcohol misuse. Revisit the cold injury section.
Next, a hiker is found dead in the freezing wilderness, partially undressed, winter clothes neatly folded nearby. What physiological phenomenon explains this deceptive scene?
That is paradoxical undressing. Severe cold-induced delirium causes exhausted peripheral blood vessels to suddenly dilate. The flush of blood makes the freezing brain believe it is experiencing burning heat. Revisit cold injury, behavioral abnormalities.
Almost done. You're investigating an industrial accident. Why does an electrocution victim often tightly grip a live, high-voltage wire and become completely unable to let go?
The hold-on effect. Currents above 30 milliamperes cause tetanic muscle spasm. The flexor muscles are vastly stronger than the opposing extensors, forcing an unbreakable clenched grip. Revisit electrical injury.
Final question. What is the name of the transient, reddish, fern-like erythema found strictly on the skin of a lightning strike victim?
The Lichtenberg figure. The definitive pathognomonic marker of a massive electron shower. Revisit the death from lightning section. So, what does this all mean for you as a clinician or a pathologist? The overarching theme is undeniable. The elements leave distinct, readable pathological fingerprints. But they are also absolute masters of illusion, mimicking violent crimes or killing efficiently with no external marks at all.
This raises an important question and leaves us with a final provocative thought for you to mull over. Our forensic interpretations in these environmental fatalities rely profoundly on fundamental physics. Ohm's law dictating the hold-on effect, thermodynamics predicting burn severity, thermal expansion creating a fake skull hematoma. The best forensic pathologists are as much physicists as they are physicians. Next time you look at a scene, ask yourself carefully, is the body telling the story of a human suspect or merely echoing the violent story of the environment itself?
A brilliant point to end on. We highly encourage you to open your copy of Simpson's Forensic Medicine, read through Chapter 12, and consolidate these structural anchors. Thank you for studying with us, and goodbye until the next deep dive.